Today we're going to be dealing with an approach to a patient with an acute kidney injury. And our lecturer for today is Dr. Anna T. Wilson. As you all know, ma'am is a professor in the Department of Nephrology. Ma'am has interest in chronic kidney disease, its pathophysiology, complications, and also in looking at low-cost alternatives to dialysis. Ma'am is an avid reader, avid writer, and a mother to very enthusiastic young children. So just before we start, I'd like to remind you all that if anyone has any doubts during the lecture, please put it up in the chat box and we'll try to come to all of it at the end of our lecture. Over to you, ma'am.
Thanks, ma'am. Thanks. Right, so hello everyone. Generally, the faculty who takes the lecture on acute kidney injury gets a barrage of all the best and best of luck messages, usually the evening before and at least 1 hour before the presentation, because it's the one lecture no one wants to take. The reason being, you can talk for an hour and you still won't know, jack about the topic. I'm just an eternal optimist, so I just hope it is different. So let's start. We've got a lot of ground to cover. Right, some problems with the cursor. Okay, so what we're going to cover, more important, what we're going to cover is actually what I will not cover, and that is, I won't be talking about individual causes of AKI as well as dialytic management of AKI, because if I talked about individual causes of AKI, we'd be here till tomorrow morning, and I think dialytic management of AKI is a separate lecture for all of you. So we'll just cover the basics of AKI. All right, so let's start with epidemiology. So why should we bother? That's because AKI is not only common, it's also in our setting preventable and treatable. And yet, if you don't manage it properly, there are a lot of completely undesirable outcomes that you can get. This study from SGPGI in India looked at over 5,000 admissions over a 5-year period in the nephrology department. 240 of those cases were acute kidney injury. What's interesting is the authors decided that AKI was defined as a creatinine of more than 2, and they excluded patients with diabetes and CKD. Now, automatically, when you do that, you're not only selecting a population that has most likely severe AKI, but you're also probably grossly underestimating the incidence of AKI. So not surprisingly, medical causes accounted for the majority, more than 70% of the AKI cases, and the big 3 were diarrhea, malaria, and sepsis. Obstetric and surgical causes much lower down the list. Because this was a tertiary referral hospital and they seem to have chosen patients with more severe kidney injury at baseline, it's not surprising that more than 80% required dialysis. But this is not the story of acute kidney injury in general in the community. This is what the picture you get when you're in a tertiary referral hospital. This study is from our hospital. This is done by Dr. Basu from nephrology and Anugrah Krispal from medicine. Published in one of the top nephrology journals in 2011. So they looked at all the admissions to medical wards over a period of 1 year and focused on those who had an acute febrile illness at presentation. Similar to what we see, what we're familiar with, scrub typhus was the most common acute febrile illness. 41% had AKI. This was using the criteria which was most prevalent at that time, which is the Rifle criteria. 8% required dialysis, and there was 12% mortality. What's obvious from this figure is that as the degree of kidney injury increased, obviously both dialysis requirement and mortality increased as well. And in the failure group, mortality was as high as 40%, and dialysis requirement was around 45%. And this is similar to data from all over the world, in fact. But what is different about acute kidney injury in a country like India? The first is that it's a disease of the young. This has a huge economic impact because this is a socially productive section of the population, and they do tend to have fewer comorbidities, very different from the population you would see in the West. The etiology is usually community acquired, usually a single cause. Sometimes it may be modified or complicated by NSAIDs and herbal medications. patients tend to be relatively hypovolemic when they come to us because of the prevailing climate. There's also an element of malnutrition. But importantly, in our setup, they come to us pretty late because access to ICU care and dialysis is not universal. And for this reason, we often see more severe versions of AKI than, say, the West would see. So let's look at AKI. The most important thing to understand about AKI first is to understand how the kidney works. So this is a diagram of the kidney. So blood flows in through the afferent arteriole, gets into the glomerulus, goes out through the afferent arteriole, and then the peritubular capillaries. So the first step is filtration, which takes place when an ultrafiltrate of plasma moves from the glomerulus right into the tubules. So that's the first step, that's filtration. The next step is reabsorption, where the kidney basically reabsorbs what the body needs, which is generally sodium, potassium, bicarbonate, glucose, water, and some amino acids. The next step is secretion. So waste products are secreted. These include urea, creatinine, and a whole lot of organic acids. And finally, less than 1% of what was initially filtered actually makes its way out as urine. So you can understand how when there's an abrupt injury to the kidney, all of these processes are affected. So excretion of nitrogenous waste is affected, extracellular volume suffers, as do electrolyte and acid-base balance. There was a term that was used not too long ago, which was acute renal failure. And there's often a lot of confusion between acute kidney injury and acute renal failure. They mean the same thing? They don't actually. So the reason why we've moved away from the term acute renal failure is we were often waiting too late to treat an injury to the kidney. We now know that even small injuries to the kidney have a huge impact on morbidity and mortality. And the term AKI was coined so that people would learn to recognize injury at an earlier stage, and this would hopefully improve outcomes for patients. So acute renal failure is now reserved for only that class of kidney injury, which is severe and requires dialysis. It just forms a small part of the entire universe of patients who have acute kidney injury. So how does one detect this loss of kidney function? Well, creatinine we are familiar with, urine output we're familiar with. Some of you may even know that we could either measure GFR or calculate in GFR using various equations, but all of these have some problems. And I want to focus on this because it's central to our idea of acute kidney injury and why we're so bad at diagnosing it. So what's wrong with creatinine? If you look at this, this diagram, the first thing you'll notice is that creatinine tends to lag woefully behind GFR changes. So look at this. The GFR has to drop by more than 50% before you begin to see a bump in the creatinine. And thereafter, even with very little change in GFR, you will see huge rises in creatinine. So it lags behind GFR. That's the first major problem we have with creatinine. So in the early phase of AKI, the creatinine may remain normal while the GFR is falling. So you're actually overestimating GFR. And when a patient is recovering from kidney injury, the urine output may have improved, but the creatinine hasn't fallen yet. So you're actually underestimating GFR. Creatinine is removed by dialysis, which is one reason why we always tell you, please don't check a creatinine after dialysis. It depends on muscle mass. So for children, the elderly, women, patients with liver disease, those who are malnourished, it's not a good marker. It's affected by hydrations. When a patient comes in and you pump them with fluids, you will get a falsely low creatinine. And then you're kind of surprised when the next day the creatinine bumps up. Well, actually, you just artificially lowered it by hydration. What's wrong with GFR? Firstly, it's difficult to measure directly. Anyone who's tried to collect 24 hours of urine, either yourself or get a patient to do it, would realize it's a futile exercise. Even if you're not measuring GFR, but trying to calculate it using an equation, you know that because creatinine lags behind actual GFR changes, any GFR you calculate using creatinine would also lag behind actual GFR changes. So you haven't gained much. And not only that, all the equations that we use to calculate creatinine are only valid when creatinine is in steady state, which is absolutely not the case in acute kidney injury. So there's no point really using any of the eGFR equations in this population. And what's wrong with urine output? Often patients don't report a decrease in urine output till it's too late. And we know that we see a lot of fluctuation in urine output. This is especially so in the ICU. You may find a transient drop in urine output. But what we know is clinically significant is not these transient fluctuations, but a sustained reduction. And so you often have to monitor the patient over a certain period of time, usually at least 6 hours, before you see a trend in urine output. There's also this entity called a non-oliguric AKI, where there's definite damage happening in the kidney, but you're lulled into a false sense of security because the urine output hasn't dropped. And we all know how difficult it is to monitor urine output outside the ICU setting. So these are the problems with urine output. Unfortunately, these two are still the most practical indices that we have. Creatinine is cheap, so you can keep measuring it. It's easily available. It's also easily measured. Urine output, despite its problems, we at least make do with shift-wise monitoring of urine output over 6 to 8 hour shifts. That's often what we go by in the wards. And once a patient is discharged, you can actually teach them to keep an intake output record. So we kind of make do with these two imperfect tools. So let's talk about how to define AKI. Now there have been a lot of criteria, and I'm not going to go into all of them because this is the one that you need to know. This is currently the most accepted criteria. It's called the Kdgo criteria, or the Kidney Disease Improving Global Outcomes criteria. All right. So you just need to understand that there are two parts to this criteria. You could either have there's a creatinine-based criteria and a urine output-based criteria. And any one of these, if you fulfill, you would be diagnosed with acute kidney injury, right? So either increase in creatinine by at least 0.3 within 48 hours, or by 50% within 7 days, or a low urine output defined as less than 0.5 ml per kg per hour for at least 6 hours. What is very important to understand, and which most people, including nephrology registrars, forget, is that you have to optimize a patient's volume status and rule out urinary tract obstruction before you diagnose a patient with acute kidney injury. This is crucial. Once you have diagnosed a patient with acute kidney injury, the next step is to find out what stage of AKI they have, right? So there are 3 stages of AKI. So here we are, stage 1, stage 2, stage 3. Not surprisingly, the higher creatinine you have, the further along you are in terms of staging. So if you have a creatinine that is 1.5 to 1.9 times the baseline, you would be in stage 1. 2 to 2.9 times would be stage 2, 3 times baseline, or a creatinine above 4, or the need for dialysis would mean you are stage 3. So any patient requiring dialysis is automatically stage 3. The urine output criteria likewise progress, along the line. You can easily access this online, this criteria, and maybe have it, save it somewhere on your smartphone. It's something you would need on the wards, right? Another thing that people often don't realize is that urine output, when you have an ml per kg per hour, definition for oliguria, what body weight you use is crucial here, because in a patient who is either morbidly obese or cachectic, you would get an erroneous estimate of their output. So the current recommendation is to use the ideal body weight when you use the urine output criteria. And it should not be used in patients who are receiving diuretics. And there is some evidence now that a urine output with less than 0.3 ml per kg per hour may be more predictive of an acute kidney injury than 0.5 ml per kg per hour. I mean, this is not accepted yet, but there's at least one study that shows this, but the criteria as of now stays the way it is. So the recommendation is that when both criteria are met, when you meet both urine output and creatinine criteria, there is no doubt that death and dialysis are increased, right? But what do you do if someone is, say, stage 1 on one criteria and stage 2 on the other? You must use the criteria which results in the least favorable stratification. So basically, that means you would stage them as stage 2, right? As with all criteria, there are problems with these criteria as well. So the diagnostic criteria do not tell you anything about the etiology of AKI, and we know the etiology of AKI has a lot to do, and I mean determines the patient's prognosis and outcome to a large extent, as well as their management. The other thing is, when you're talking about a rise in creatinine, it's always in relation to a baseline creatinine. How do you know what a patient's baseline creatinine is, especially in our setup where they may be coming to the hospital for the first time? So one group of experts say, let's assume that everyone had a normal GFR. Let's assume they had a GFR of 75 and back calculate a creatinine from there, right? But obviously, this doesn't make sense because then you would miss out on the group of patients who had an underlying CKD. So no one really follows the first recommendation, right? The most practical thing is to use the admission creatinine. And this is often what we do. We have the admission creatinine, and then we look at whether there's a rise over the next 48 hours or 1 week. If, however, you have creatinine values within the last 1 year, the most accurate estimate of baseline creatinine is just to take an average of the creatinine values over the last 1 year, okay? Now, in a patient who has a high creatinine, okay, at baseline, say their creatinine when they got admitted was 4, right? And 48 hours later, that creatinine is 4.3. Does this patient really have an AKI? And there's definitely a problem with a high false positive diagnosis when the admission creatinine is more than 1.5. This is because there's an inherent biological variability for creatinine. And the higher the creatinine is, the more this variability is. So you might actually overdiagnose AKI in patients who have a high baseline creatinine. And this overdiagnosis can be to the tune of 30%, not an insignificant number. Something to keep in mind. It may be better to have a few more creatinine trends before you actually make a diagnosis of AKI in someone who has at admission high creatinine. Okay, for all you know, it may be a CKD. Right, and nephrologists are up in arms because, especially with the urine output criteria, there's a barrage of nephrology consultations. We see this a lot in ICU. Urine output kind of trending low over 6 hours, there's immediately a ping to the nephrologist, and by the time we come to see the patient, the output has picked up. Anyway, that's something we all have to live with. So what is the current use of these diagnostic criteria? It's in prognosis, in terms of mortality and the length of their ICU and hospital stay, and definitely in terms of research. But for us, of course, in the hospital, it's prognosis that we're interested in. Now, what about biomarkers? Now, I must confess, I'm not much of a fan of molecules. And this is the reason why. So this slide is deliberately busy to tell you that there are all these molecules that have been found to be markers for acute kidney injury. But as with any page that has a lot of information, generally you'll realize that usually it's a lot of information, but yet not much help. And so if you want to know the role of biomarkers in acute kidney injury, I'll just summarize it for you on this slide. And that is, as of now, biomarkers have only been shown to be of any use in AKI prediction or prevention, which means if you found a biomarker which was elevated right at the start, okay, sometimes even before, if the patient is going in for a high risk, just after they've had a high risk procedure, say coronary artery bypass surgery, and you find that their biomarker is positive, this is definitely a patient you would need to monitor because they are likely to develop AKI. The reason this is because biomarkers are molecules released from the cells when they are injured. So unlike creatinine and urine output, which are markers of function, these markers are actually markers of injury. That is really the crux of the matter. That's why people are excited about them, because if they're elevated, it points to actual tissue injury, right? But unfortunately, in terms of diagnosis, severity, etiology, management, not much use. So right now, it's only recommended that you use them for prediction or prevention if you have access to them. Cystatin is something that's available with us. And there's at least one study that has shown that, say, for vancomycin dosing, if you used an EGFR, which combined creatinine and cystatin, and we're talking about the CKD, EPI, creatinine, cystatin, EGFR, you would increase the time that vancomycin was in the therapeutic range by up to 22%. So definitely cystatin is adding something, in terms of giving us a more accurate prediction of the renal function than if you just use creatinine, all right? And of course, if you're someone who loves molecules and wants a few publications, anytime you want an AKI, you do an AKI study with biomarkers in it, you're sure to get published. But what are the disadvantages? It's expensive, not easily available, definitely not in our setup, varying cutoffs. And so far, there is no biomarker that has been shown to do better than simple clinical prediction models in terms of, predicting people with acute kidney injury. So as of now, the jury is still divided. However, there's a group that seems to be very keen on bringing biomarkers out, into the public space. And they have suggested that in the AKI diagnostic criteria, which I talked to you about, the presence of a biomarker should indicate that that patient has a higher degree of kidney injury. So they have proposed that the kidney injury classification should actually look something like this. So suppose someone is in stage 1, kidney injury, they would be said to have a higher degree of kidney injury if they were biomarker positive than if they were biomarker negative. And they actually propose a whole new strata of acute kidney injury in which there's neither rise in creatinine nor fall in urine output and only a biomarker positive. This is like a silent AKI, right? This is just a recommendation as of now. It has not been approved or, taken up by Kdgo, but maybe we'll have to watch this space. Right. Time for people to get active in the chat box. Okay. So based on what you've just heard, if you were listening, which of the following would suggest an AKI? I can't, wait, I'll have to take a look at the chat box myself. Right. Everyone was sleeping, I guess. Oh, okay, it takes time to read. Right, okay. I'll give you maybe 30 seconds more. Or maybe we can do this right at the end, but 30 seconds. Okay, C, Ria. You know, what if I told you that the answer was, there could be more than one correct answer? C is correct. Yeah, yes, that's C and D, correct. So C, so this is obvious. There's within 48 hours, there's more than a doubling of creatinine in 48 hours. So this is definitely AKI. This more than 1 year ago is probably CKD, right? This is something I want to talk to you about because I won't be covering it in the lecture. When you have a definite rise in creatinine, which has taken place recently, but not within 1 week, it's what we call acute kidney disease. It's not called acute kidney injury. It's called AKD, acute kidney disease. Anything that happens between 7 days and 1 month, so not exactly AKI, is called acute kidney disease. So this would be AKD. And this is what I told you about. I mean, the creatinine has not really reached the 0.3 target we're looking at. Urine output is just about 0.5 ml per kg per hour, not yet 6 hours, but we have a biomarker that's elevated. So yeah, this would suggest an AKI, right? Okay, good. Let's move on. Pathophysiology, something no one is interested in, but if you don't understand pathophysiology, well, you'll find it difficult to treat your patients. So the best way to understand pathophysiology is basically to think of the kidney and all its compartments, right? So pre-renal acute kidney injury is any insult that reduces blood flow to the kidney, right? This could be hypovolemia or cardiac failure or HRS, right? You could have something affecting the renal artery. You could have things affecting small vessels, usually thrombotic microangiopathies or vasculitis, move down to the glomerulus, any number of glomerular diseases. From the glomerulus, you move down to the tubules. We're all familiar with acute tubular necrosis caused by a host of insults. Next to the tubules, you have the interstitium. Drugs, infections, and other diseases can affect the interstitium. You can have tubules blocked by crystals or casts. And finally, you could have an obstruction anywhere along the urinary tract, right? So these are the common causes of kidney injury. And please remember that especially in our setting, we often see a combination of many of these. So we very rarely see a pure pre-renal or a pure intrinsic renal. Often we see a mix of, many. Right, so let's look at pre-renal AKI. So whenever there's a decrease in the effective circulating blood volume, our body reacts by immediately activating 3 major systems. And these are the renin angiotensin system, the vasopressin system, and the sympathetic nervous system. And all they do is they just ensure that the brain and the heart get enough blood. How they do this is they tell the kidney to start reabsorbing salt and water, okay? They get us to start taking in more salt and water, right? And the sympathetic nervous system will just make our heart, pump faster, increase the cardiac output so that blood supply to essential organs is maintained. And all this is done at a cost to the kidney because the kidney is one of the organs that go into vasoconstriction apart from the skin and the skeletal muscles. Now, understanding that salt and water are reabsorbed will help you understand many of the urinary changes you see in pre-renal AKI. So because salt is reabsorbed, you would expect a low urine sodium, a low fractional excretion of sodium. Along with water, urea is also absorbed. Because of urea being absorbed along with water, less urea is excreted. So the fractional excretion of urea is reduced in pre-renal AKI. And because you're reabsorbing water, your urine becomes more concentrated. So you expect that the urine osmolarity would increase. Is this understood? Because if you don't understand this, many of the urinary indices you would not understand. Okay? Right. So important to understand this whole thing about autoregulation. So this kidney is a wonderful organ that between 80 and 150 millimeters mercury knows how to look after itself, right? So what it does is, suppose the blood pressure falls below 80, now what it does is it asks prostaglandins to dilate the afferent arteriole. This automatically sends more blood speeding into the glomeruli. And it also tells angiotensin 2 to actually constrict here. The combination of a constriction here and a dilation here will actually increase pressure here, and that maintains GFR, right? So what happens when you have an NSAID? It blocks afferent arteriolar dilatation. What happens when you take an ACE inhibitor or an ARB? It blocks the other side. So either of these, this is why they affect autoregulation and cause AKIs or promote AKIs, right? If you have severe hypovolemia and the BP falls below 80, automatically autoregulation would fail. But apart from these, there are a few conditions in which autoregulation is impaired even in this range. So CKD patients, elderly patients, diabetics, hypertensives, they have an impaired autoregulation. So even minor fluctuations in their blood pressure, something that wouldn't cause a blip in a normal patient, would cause an AKI in these patients. Important to understand in the ICU because we are used to maintaining a set map. But remember that these patients may need a higher map simply because their autoregulation is impaired, right? Okay, what about glomerular causes? You're all familiar with nephritic and nephrotic syndromes. Both are associated with acute kidney injuries. In the nephritic syndromes, basically, the glomerulus is chock full of inflammatory cells. They close down all the capillaries, and there's just no room available for filtration. So automatically, this results in a fall in GFR. Okay, when there's a fall in GFR, the tubules, which are actually untouched, get the feeling that there is a pre-renal AKI. So they start reabsorbing salt and water, okay? And meanwhile, this inflammation is also causing damage to the GBM. So this explains everything that we see in a nephritic syndrome, right? The fall in GFR is what causes the deranged renal function. The creatinine starts rising. The salt and water retention is what causes the edema and the hypertension, right? The fall in GFR also causes oliguria. And the damage to the basement membrane is what causes blood and protein to appear in the urine, right? So if you understand this, nephritic syndrome is simple to understand, right? In nephrotic syndrome, what causes the AKI is that there's marked hypovolemia because of hypoalbuminemia. So there's third spacing. And sometimes you'll use a diuretic on top of it for the edema, and that just worsens the hypovolemia. Apart from this, when there's so much protein leak, it may actually block the tubules with casts, and that causes an ATM, right? Okay. We need to understand ATN as well, because it's such an important it's such an important pathology for us, especially in our setting. So in the early stages of an acute tubular injury, what happens is that the cytoskeleton just rearranges. And a lot of the transport proteins which were there in the basolateral part of the membrane now move to the apical surface. Why is this important? One of the most important transporters is the sodium potassium ATPase. When that moves from the basolateral to the luminal surface, sodium actually starts leaking into the lumen, right? And this has important consequences, which I'll come to in the next slide. Just hold this thought in your mind, because you will need this information to understand what I'm going to talk about next, okay? Suppose there's still more injury, okay? AKI hasn't reversed. Then the cells start dying and they start falling into the tubules and they'll form casts, okay? And this is when they actually, GFR starts dropping, okay? Now, the question people often ask is, when it's only tubular injury and the glomeruli are fine, why the hell should there be a fall in GFR? And the answer to that question is this phenomenon called the tubular glomerular feedback, okay? Now, what happens here is there's something called the macula densa, which I'm not going to go into too much detail about, but it's somewhere over here, right? And this macula densa, whenever it senses more sodium coming to it, it thinks that the GFR is increased, okay? and it then immediately tries to clamp down on the GFR. So if you go back to the previous slide, I told you that because of this rearrangement in cell proteins, sodium actually, those transporters are now at the luminal membrane and sodium starts leaking in the tubule, right? That increased sodium reaches the macula densa. And what does the macula densa think? It thinks, my gosh, there's too much blood flowing through this kidney. I got to shut this down. So it sends secondary messengers all the way to the afferent arteriole and makes the afferent arteriole constrict. And what does that do? It causes a fall in GFR. So this is the reason why you have a GFR fall in acute tubular necrosis. Okay? All right. Why the heck should this happen? Because it's actually protective. When you drop GFR, the tubules downstream need to work a lot less. So they will consume less ATP, and these ischemic tubules will hopefully recover. So the body is basically cutting its losses. Let's look at interstitial nephritis. In our setting, it's most commonly drug-induced and often non-oliguric. This classic triad, which everyone talks about, is very, very uncommon, but you're more likely to see it with penicillins. The way in which interstitial nephritis causes damages, these drugs cause damages, they'll actually either bind to some component of the tubules and just generate an inflammatory reaction, or they may cross-react with endogenous antigens, or they may just get trapped and cause an inflammatory reaction, or they may form immune complexes which get deposited. Whichever way they cause damage, the damage starts in the interstitium and slowly the tubules are involved, and you know what happens after that. Right, what about obstructive uropathy? You just need to understand this. When you have an obstruction in the urinary tract, that causes a back pressure to be transmitted all the way up, right, to the tubules, okay? This rise in tubular pressure basically will prevent filtration from the glomerulus, okay? And that is why GFR finally drops. Please understand that many of these things and the downstream effects, inflammation and chronic damage, begins to happen as soon as 24 hours, which is why in the case of obstruction, time is kidney. You have to relieve an obstruction as soon as you get to know about it, okay? This is also the reason why in any case of AKI, they say, please get an ultrasound to make sure it's not an obstructive uropathy, especially if someone comes with anemia, all right? Okay, assessing the patient. I cannot begin to tell you how important a history is in AKI, because you need a whole lot of information that only a history can give you, right? So the first thing is about looking at risk factors and exposures. Basically, you want to see if your patient is someone who's susceptible to an AKI in the first place. And who are these patients? Those who are elderly, women are prone to obstetric causes of AKI, diabetics, those with comorbidities, those with malignancies, and those with an underlying CKD, right? And then if you have a marriage between someone who's susceptible and bad exposure, you get an AKI, right? As surely as night follows day. So any of these exposures would result in an acute kidney injury, right? So when you know you have a high-risk patient, and you know that high-risk patient has had an exposure that could put them at risk for AKI, please monitor this patient daily with at least creatinine and urine output, okay? What we often as nephrologists see is a creatinine being checked 4 or 5 days after an insult. And often by that time, there's been a lot of damage. So this is part of the reason why I really want to drive this through is in the wards, you have to be zealous about looking at your patients, at-risk patients, and ensuring that you follow them up regularly, right? So again, I mean, this is basic stuff. I'm sure all of you know this. So there's certain history that would tell you this is a pre-renal AKI. A glomerular disease, you would think of anyone with hypertension, hematuria, edema. We've gone over most of this, so maybe I'll just, okay. So if you have someone who's come with suprapubic distension and having difficulty voiding, this is most likely someone who has a bladder outlet obstruction. Likewise, a history of loin pain or hematuria, please think of something in the upper urinary tract and please get an ultrasound done. Never forget to take a drug history, a travel history, and an occupation history. They can give you very important information. Never forget to examine a patient, especially to rule out pre-renal AKI, because some of the signs you will not get any other way. I want to also tell you about blood pressure. Very often, all you may get is a postural fall in blood pressure. You need to be sensitive to that, right? Right, we'll just skip this. So palpable bladder, renal angle tenderness. Don't forget to do a pelvic or a rectal exam in a patient with to rule out a malignancy. There are some signs and symptoms that are common to all causes of AKI, and these are due to either accumulation of waste products, accumulation of fluid, dyselectrotemia, or acid-base disturbance. For example, the acidotic breathing that we are quite familiar with. All right. Just to give you guys a breather, can anyone tell me what fish this is, or what family this fish belongs to? Anyone from Central or Eastern India? Not that I want to be, but they're most likely to know the answer to this. Okay, 30 seconds. Come on, guys. It's an uncommon cause of AKI, but it's an interesting cause of AKI. I've even seen a couple of patients with it. Right, no takers. Okay, so this fish is a member of the carp family. It's the family that rohu and katla and all those tasty fish belong to. But the reason it's up here is because in India, and not just India, and whole lot of countries in Southeast Asia, the fish gallbladder is an aphrodisiac. Okay, and it's unfortunately, if you believe in fish gallbladder more than Viagra, and you have 3 or 4 fish gallbladders, you can lose your kidney, your liver, your heart, and very likely your lung, your life. So fish gallbladder poisoning, very common in Eastern, not very common, but mainly described in Eastern India and Jharkhand, Chhattisgarh, that area, right? And usually this kidney injury, if they do survive, they often end up with CKD. It's usually a non-reversible cause of CKD. Okay, so there's a toxin in the bile that goes in, basically finishes everything off. Right. Right. What investigations to order? Blood urea and creatinine. We all know this. But if you have a urea which is much higher than creatinine, this is usually suggestive of a pre-renal AKI. Like I told you, urea is reabsorbed. So you will find a urea much higher than creatinine in pre-renal AKI. Please just note a few other causes of such high urea creatinine. A GI bleed, because the urea in blood is broken down and reabsorbed from the gut. Anyone in a hypercatabolic state, and someone on steroids. These are other causes for the urea being higher than the creatinine. Creatinine can be much higher than urea in rhabdomyolysis because creatinine is released from muscles. Sodium, potassium, can vary. Calcium is also variable. Phosphorus in AKI is usually high because it's not, there's a failure to excrete it. And what is so important in AKI, but which doesn't get much emphasis, is doing a proper urine analysis. So if the patient is passing any urine at all, please send it for analysis. You're looking for dysmorphic RBCs, which will point to a glomerular pathology. You're looking for muddy brown cast that would point to an ATM. RBC cast that would point to a glomerular disease, and WBC cast that would point to an interstitial disease or a pyelonephritis. Okay. And if you're thinking of a drug-induced interstitial nephritis, please ask for a urine eosinophil count, and more than 1% may be suggestive of AN, but make sure the patient doesn't have a UTI or prostatitis or hasn't received recent contrast, because that can muddy the waters a bit for you. Ultrasound is always important to rule out obstruction. And apart from that, if you don't see an obstruction, but you see some signs like a small kidney, scarring, loss of CMD, this means the patient has either a CKD or an AKI superimposed on a CKD. So these are the 2 reasons why you should get an ultrasound done, both to rule out CKD and obstruction. Now, a whole lot of urinary indices, none of which are used in practice, but which people ask you in the exams. I'm just going to cover it because I have to, but not because I believe in them. All right. So forgive me. Fractional excretion of sodium. Like I told you, sodium excretion is reduced. So when you divide urine sodium by serum sodium, when you do this, obviously in pre-renal AKI, you would have a low fractional excretion of sodium, whereas in ATN, because the tubules are leaking sodium, you would have more sodium in the urine and you would have a high fractional excretion of sodium. Okay, there are a whole lot of caveats. And this is the reason why I'm not very fond of these indices. If a patient, for example, is on diuretics, you could have a pre-renal AKI and still have a high serum sodium. Okay. If you have CKD, even if you had a pre-renal AKI, your kidneys your tubules are not functioning well, so you would leak sodium anyway. So this is the reason why we don't usually check these indices, right? Again, same thing with urine spot sodium. Less than 20 is supposed to suggest a pre-renal AKI, but again, if you're on diuretics or have CKD or something, this is not it's not accurate. Okay. Fraction excretion of urea, because urea is reabsorbed, a low fraction excretion of urea would point to a pre-renal AKI. This may be useful in patients on diuretics, but this is not something we ever check, right? You would have a highly concentrated urine in pre-renal AKI and higher urine osmolarity. Okay. Some other factors that you might look at, which will point you to the cause of AKI, maybe say neutrophilia in sepsis, thrombocytopenia, you'd think of maybe a thrombotic microangiopathy if there's no sepsis. Eosinophilia would point to an interstitial nephritis. A low calcium may point towards tumor lysis or rhabdomyolysis or pancreatitis. A high calcium may be there in myeloma. If there's urine protein, it's always good to send a workup for acute GN, at least a C3, C4, and you can wait on the serology. There's something I really want to, really emphasize on. If your urine analysis shows protein, and I mean this even for patients who don't have a glomerular nephritis, even a dipstick 1+ or 2+ identifies patients who probably may not recover fully from AKIs. This is an important test. Just a dipstick protein, this is simple urine protein, will actually identify a subset of patients who may not fully recover from an AKI, even if you're not talking about a glomerular disease. Okay. Right, very busy slide. Please pay attention only to the top and the bottom, because like I said, those urinary indices are just not practical. So a combination of history, urine output, and examination is the best way to tell you whether you're dealing with pre-renal, ATN, or post-renal. Okay, combined with urine microscopy and ultrasound. Okay, this is simple, practical, what all of you can do. But the gold standard test is the last in the list, which is how a patient responds to volume depletion. If this patient after volume depletion improves their urine output, without a doubt, this is pre-renal AKI. Okay. If this patient is not responding to volume depletion, you're left with one of the remaining two. Hopefully you would have already ruled out a post-renal by doing an ultrasound, right? This is a very important slide because it's often something lots of people struggle with. Is this an AKI? Is it a CKD? Is it both? The duration of symptoms is one important thing to go by. So a shorter duration, a recent onset of oliguria, but please remember there's always a non-oliguric AKI. Almost every one of these factors, there is a caveat, which I've mentioned. So AKI patients look very sick, but if you see a patient who has really high creatinine and sitting in front of you and smiling, it's very likely a CKD because the investigations look worse in the patient. Nocturia is a very important history to elicit because that is usually seen in CKD. You'll find most of us nephrologists ask our patients whether they have nocturia, okay? Which, a creatinine trend rising daily may point towards an AKI. Normal sized kidneys point toward an AKI unless patient has an underlying CKD. But please remember that there may be CKD patients who actually have a normal sized kidney, and those exceptions often asked in the exams are written here. Diabetes, ADPKD, and obstructive uropathy, normal sized kidneys, even though they have CKD, okay? Anemia points to a CKD, right? Except if it's an AKI associated with hemolysis or if it's the prior CKD. PTH is another important test, okay? Usually normal in AKI, but again, if the patient has underlying CKD, you may have a high PTH. So really the confusing part is when you have an AKI on CKD, but hopefully you would have, your hotshot clinicians, I'm sure you'd be able to make out the difference, right? When do you want to do a kidney biopsy? If you have a prolonged AKI or you're suspecting a GN or an interstitial nephritis, or you have some systemic features, that's when you call up your nephrologist and ask them to do a biopsy for them. So this is what an ATN would look like, a lot of necrotic cells falling into the tubules. And in cortical necrosis, basically everything's gone and you're left with a ghost. Okay, management, we're nearing the finish line, praise God. So most importantly, please assess volume status at admission because it affects everything you do thereafter. Monitor blood pressure, urine output, check weight, ensure the plasma glucose is not too low and not too high. Please make sure the patient isn't starving in the ward because these patients are already hypercatabolic. And please don't restrict their protein, right? Ensure that even in non-catabolic AKI, they get around 1 gram. And if they're on dialysis or on CRRT, you really need to go bonkers, giving them enough protein. Otherwise, they're going to be breaking down their muscle and become hypercatabolic. Okay, so please don't restrict protein and ensure they get enough calories. Not going to go into detail. There's a whole lot of anti-hyperkalemic measures, but there's one thing I want to tell you. When you do any of these things in casualty and then ask a nephrologist to dialyze the patient, What you've done by giving any of these things is you've pushed potassium from the plasma into cells, right? And what does dialysis do? Dialysis can only remove potassium which is in the blood. So if you've moved potassium from the blood into cells, as a nephrologist, there's very little I can do to remove the potassium that is not in the blood, right? So then what happens is we finish dialysis, and an hour after dialysis, we get a phone call from medicine saying, you know what? You did a really bad job of your dialysis, because after your dialysis, the patient's potassium is 6. And we're kind of smiling to ourselves, but we go ahead and do another dialysis. But this is the reason why. Okay, this is not to say that you shouldn't do it. In the casualty, you often have to do these things just to keep the patient alive. But please understand that any subsequent dialysis will be that much less effective in removing potassium. Okay. Metabolic acidosis. Give sodium bicarbonate only if pH is less than 7.1, and if the patient is already fluid overloaded, please don't waste your time. Call the nephrologist and get dialysis started. Okay, I'm not going to move into calcium and phosphorus, except to say that treat hypocalcemia only if it's symptomatic. Okay, and especially if the patient is asymptomatic for the hypocalcemia and the phosphorus is high, just bringing down the phosphorus will bring up the calcium. So you don't need to really jump at every calcium that you see unless, patient is symptomatic, okay? Right, so pre-renal AKI, the goal is volume replacement. All of you guys, you know this because you spend enough time in the ICU. Yes, but this is what I want to emphasize on. If there is no improvement in urine output, despite adequate volume replacement, this is a volume unresponsive AKI, right? Please avoid fluid overload, because all you will do is make this patient spend more time on the ventilator and increase their mortality. At this time, what you need to decide is whether you want to give this patient a diuretic or you want to start dialysis. Here comes the really popular furosemide stress test, okay? So this test is believed to predict requirement for dialysis. Well, it's been shown to predict requirement for dialysis. And what it involves is giving a bolus dose of 1 milligram per kg of furosemide if this patient has never had a diuretic. But if the patient has received a diuretic in the last 1 week, you give a higher dose, that's 1.5 milligram per kg. What you're looking for is the urine output in the next 2 hours. This patient is said to have failed the test if there's less than 200 ml urine in the next 2 hours. Right? This basically means they're diuretic unresponsive. Okay. But what people have argued that it's wrong to just give a standard 200 ml cutoff. It could vary depending on a patient's size, for example. So a Japanese group took this into account and coined a new term called furosemide responsiveness, which is basically taking the 2-hour urine output after you give the furosemide stress test, divided by the furosemide dose you give. And they showed that a dose which is less, output less than 3.9 ml per milligram was what predicted dialysis and death. So maybe in our population, this may be more apt than using a standard 200 ml cutoff, okay? Right. What are the advantages and disadvantages of diuretic? So the clear advantage is that you prevent fluid overload. There are a whole lot of other things which haven't been proven, but which people talk about. And the disadvantage is that it just makes you delay dialysis, okay? Because people think you can prevent AKI, you can reduce the severity of AKI, you can reduce the requirement for replacement therapy. None of those have been shown to apply. All you do is actually you delay dialysis, and it may cause volume depletion, right? So please use diuretics only if the patient is fluid overload. Don't use it to convert an oliguric patient into a non-oliguric patient, because in that patient, all you're doing is delaying dialysis. If you're using it for fluid overload, yes, there is a role for that, right? But please don't use it to delay dialysis. Right. Acute GN or AIN, please call us. We'll do a biopsy and we will tell you how to manage this patient, okay? Post-renal, please call urology. And if they're taking time, please put in a Foley's or a PCN after discussing it with them on the phone. But then be ready for what happens after you relieve the obstruction, which is a lot of diuresis. And at this point, you have to literally monitor the hourly urine output and replace it with N/2 saline. The reason being the tubules have lost their concentrating capacity. So they're losing fluid, which is the same concentration as N/2 saline. So you replace with N/2 saline, okay? Right. So what do you, patient has AKI, what are you going to monitor on the wards every day? You're going to look at weight, intake, output, blood pressure, and you're going to look at volume overload, right? Especially if the patient getting volume overload, you'll call the nephrologist and ask them to get on with dialysis. Now, investigations. Sodium potassium bicarbonate, yes, please order. Serum creatinine, please do not order if the patient has been dialyzed, okay? If the urine output of this patient is not improving, don't expect an improvement in creatinine. So please save your patient money. Don't order a creatinine. Just order a sodium potassium bicarbonate because that will tell you whether dialysis is needed. Okay. Start checking a creatinine only once the urine output starts improving. Okay. When you start dialysis, these are the often late indications, but this is what is followed in our setup. Right. And basically what dialysis is doing is just supporting the kidney and allowing it to recover. Okay. So the whole idea of starting RRT is to achieve homeostasis and to allow the kidney to recover. Okay. You may have to increase the dialysis frequency depending on how severe the kidney injuries and how many organ failures there are. Okay. So this is why, in order to decide how much dialysis and how often dialysis needs to be given, you just need to monitor acid-base, electrolyte, and fluid balance. Okay. Now, if the patient is showing an improvement in urine output, a stable potassium, and a stable volume status, this is the patient in whom you can withhold dialysis and just monitor the urea, creatinine, electrolytes daily. As long as these things remain stable, you can keep them off dialysis. All right. And how long does it take to recover from dialysis? Everything depends on how severe the injury is. Okay. Less severe injury, where you know there's just been some rearrangement of the cytoskeleton, it may recover as early as 3 to 5 days. But very severe injury in which the tubular cells have died, it may take 7 to 21 days, right? Right. So in the recovery phase, while a patient is recovering, please ensure that there are no further insults. They should not have further hypotension, hypovolemia. They should not get any further nephrotoxic drugs and contrast, and please treat a fever. Especially do not discharge while the patient is in a diuretic phase, okay? Because this is when they may become volume depleted, okay? Or if you absolutely have to discharge the patient, please make them, keep an intake output diary and try and monitor their function every 2 days. Right. Unfortunately, the scenario in India is that less than 50% of patients who present with a community-acquired kidney injury to a hospital in India will ever recover their kidney function completely. This is the reason why after discharge, you need to monitor for especially chronic kidney disease in patients who are elderly, who have comorbidities, who had a dialysis requiring AKI, and who started off with a lower GFR. Okay. And even minor AKIs, even if in patients who recovered up to 90% of their GFR, they still had an increased risk of CKD within 3 years. So this is why any patient who's recovered from an AKI, the job does not end with sending them home. You have to monitor them with blood pressure, proteinuria, and creatinine. And by 2 months post AKI, you will know whether they actually have a residual CKD or not. Okay. All right. Just a couple of important things. Okay. If a patient presents with anuria, please rule out complete bladder outlet obstruction. You have to get an ultrasound done. Okay. The other causes, rare causes, are given below that, but you have to rule out an obstruction. And this is just an important MCQ, which is this whole thing about pseudo AKI. There are some drugs which will cause a false elevation in creatinine. Doesn't mean that there's an AKI. It's just that they're interfering with creatinine secretion. All right. Right. How much time do I have, Rohan? Yeah, I'm okay. All right. So then there's time to test how many of you have been awake. So just take a look at this. Let's take a look at this and let's see what you guys have to say. Okay, there's a 35-year-old male whose weight is 60 kilos, no comorbidities, and who presents with an acute febrile illness. Oh, I think okay, acute febrile illness of 5 days duration. I missed that out. Okay, the blood pressure is 80. This is in emergency department. Okay, we have a blood urea of 45, creatinine 1.5, WBC count 13,000, 100 ml of urine has been drained. Okay, there's the ABG for you. First question, is this AKI? Why or why not? Let's see what the chat box has to say. Guys, please answer. Otherwise, I swear this will be the last medicine lecture I will take. No. Okay. Why is the next question. That's the correct answer. Okay. Depends on prior values. Correct. So we don't have a prior value. But does this patient have risk factor? Oh, muscle mass is high. We don't know that. Do we know that? 60 kgs. We don't know that. All right. We don't know his height, so we can't guess what his muscle mass is. Okay. But Rohan made an important point. We don't know what his prior creatinine is. We have only one creatinine value. But do we know that this patient is at risk for an AKI? What in this list of factors tells you this patient is at risk for an AKI? Does he have susceptibilities? Or does this patient have an exposure? Okay, low BP, correct, fantastic. Sakshi, wow. All right, my day is done. Yes, patient has low BP, high colored urine, acidosis. Okay, so among this, it's the low BP and the high colored urine, and yes, the high lactates. All this points to a patient who's at least volume depleted. Okay, we don't know yet whether this is a pre-renal AKI or whether this patient has reached an ATN. Okay, all right. Now, at this stage, what test would you like to order next? Fantastic, Ria. Great, because yeah, okay, fantastic. Yeah, okay. So urine routine, you've got 100 ml of urine in that bag, just send a urine routine. And yes, the most important test is to actually give this patient volume. Okay. This patient is too unstable for you to do an ultrasound in casualty, so that can wait till later. So now the priority is to actually give this patient volume. If this patient responds to volume, then the diagnosis of a pre-renal AKI has been made. If this patient, despite adequate volume depletion, does not improve his, so what are you going to monitor? So the treatment is volume depletion. What are you going to monitor to see whether you're on the right track? Urine output, fantastic. Along with all the other things that the, what are those called? What you see in early goal-directed therapy. I'm not very good with names. Urine output, no. So Ria, I have to correct you there. Urine output is good, but you are not going to see a change in creatine electrolytes so soon. Maybe electrolytes, but not creatinine. So immediately what you want to monitor is signs that the patient is becoming volume deplete. Okay. So whether that is whatever way you may choose to do that. One is urine output be getting improving. The other is blood pressure picking up. Then of course the other measures like if it's possible, IVC variability, pulse, all those kind of things. Okay, but the easiest things to do are to check for the blood pressure improving, right? Or the MAP improving and the urine output improving. Okay, that will tell you whether you're repleting enough. Okay. Yeah, and once the patient is in the ward, on a daily basis, then you can start monitoring creatinine and electrolytes. Remember, creatinine only if this patient is not requiring dialysis. Okay. Yeah, I think we are done. Oh, summary, right. For those of you who are joining us right now, this lecture was about diagnosing and staging AKI using these Kdgo criteria, how to take a history exam and order laboratory investigations to determine the type of AKI, how to rule out a pre-renal AKI, how to decide whether someone has a volume unresponsive AKI, what to monitor, to understand that we should not expose the patient to further insults during recovery, and what to follow up after discharge. All right. Thank you. Any questions? Especially, please make sure there are questions that I can answer. All right.
How do we decide the antibody doses in patients with an AKI?
Right. Very good question. Yeah. So as of now, the general consensus is the Cockcroft-Gault, right? But there's a lot of controversy on that. Okay. And things get even murkier once a patient is on dialysis, because every form of dialysis therapy removes drugs to a different extent. And it depends on the type of drug as well. Some drugs are more protein bound than others. So those that are more protein bound would be removed less by dialysis. Okay. And if someone is on CRRT, they would lose more drug than if they were, say, on intermittent hemodialysis. So for many of these dialytic modalities, especially CRRT, no one knows what the optimal dosing is. Okay, and it will be covered in the dialysis part of the lecture. But now people have come out with a few algorithms, but really what needs to be done is every center will have to do its own pharmacokinetic study for each form of CRRT to actually find out, and for each drug to find out what the optimal dosing is. We don't have much information, so we often end up underdosing. Okay.
So non-dialysis patient.
Generally, you use a GFR less than 10. That's the safest thing. Once a patient has AKI, the safest thing to do is to use a GFR, especially if they're oliguric and requiring dialysis. Treat them as if they are a dialysis patient. You basically say
there's the other end of the spectrum when they have an AKI but non-oliguric, and initially you are loading dose.
Yes.
The subsequent dosage should be on
correct. So you should yes. So don't compromise on the loading dose. So what they say is don't adjust the loading dose. It's only the maintenance dose that you should adjust based on the GFR, which we all know is imperfect, right? But the loading dose you should not cut down.
And the combination should ideally be Cochrane or not.
Correct. Yeah. Now, whether creatinine is a statin, so far we know that only for vancomycin it seems to be better, but no one's really looked at it for that stuff. Right. Diet and AKI. Sir, I think I did cover that. Basically, you want to have enough calories and not restrict protein. That's the lowdown on diet in AKI. The actual values are for calories 20 to 30 kilocalories per kg, and for protein 0.8 to 1 gram if the patient is not on dialysis, 1 to 1.5 the patient is on dialysis, and if the patient is on CRT, 1.5 to 1.7. That's basically it. Right. Dr. Anand, thank you, sir, for your comments. Okay. Right. So, sir, about AKIs, I actually, this is the reason why I said I wouldn't look at, I actually have slides which look into snake bite. I don't have malaria, but okay. So maybe I'll just put up the, okay, just let me just do the snake bite. I haven't actually prepared for it. I've got the slide. 1 minute. Right, 1 minute. So, okay. Oh, I don't have snake bite. I'm sorry. Yeah, okay, I do have snake bite, right. So when I took this lecture for medicine in 2014, I remember that my lecture went on for literally 2 hours, and that is because I went into all the details. So I kept it out of this presentation because I found that focusing on all these causes sometimes takes the attention away from the basic things that people need to know about managing AKI. So these are the reasons why you may have an AKI in snake envenomation, especially viperine snake envenomation, which is what we commonly see here. Pre-renal is the most common, but we do see so a lot of this data, this cortical necrosis of 20 to 25%, ATN, this is data that has been published from SGPGI in the 1960s. Now, frankly, I think it's time for us to, because I'm sure a lot of things have changed. The patients are definitely getting to us earlier. Even if they're not getting to us, they're getting to ASV and at least a primary or a secondary health center earlier. So the entire profile of the severity of AKI, the causes of AKI in snake envenomation is likely to have changed. So I would encourage medicine department to actually look at AKI and snake envenomation again. Where possible, try and do a biopsy for patients who are not recovering, and we may actually get some interesting information, right? So, but this is data published from SGPGI by Dr. Chugh in the 60s. And this is the only information that we do have regarding what the underlying pathology is in snake envenomation. Right. Any other questions? okay, we've crossed the magic hour, right? And we're all alive and hopefully awake.
All right, so thank you so much, ma'am, for the lecture and for answering our questions. Further doubts, you can contact ma'am in Nephrology. Thank you all for coming. Hope you had a useful time.